Fletcher's Solicitors are proud to sponsor the Mama Academy podcast series. We are one of the UK's leading birth injury specialists, trusted by families with the most complex legal cases. We champion better maternity care through every family's story. Fletcher's Solicitors, for every birth, for every baby, for every family. For more information about how we can help, visit www.fletchersolicitors.co.uk.
Hello and welcome to the Mama Podcast. This is the first episode in a brand new 10-part series created specifically for healthcare professionals working in maternity and neonatal care. Across the series, we'll be talking with leaders and changemakers from across the system, exploring what's needed to improve safety, equity, culture and outcomes, not through blame, but through learning, evidence, and practical solutions that can be taken back into everyday practice.
Today's conversation focuses on communication, trust, and the human side of leadership in healthcare. We're joined by Ruben Joki to explore how meaningful communication can strengthen teams, improve patient experiences, and help build cultures where people feel heard, supported, and empowered. Let's get into this episode of our Healthcare Professional series.
So welcome to this episode of the Mama Podcast. I'm Heidi Eldridge, the founder and CEO of Mama Academy. And I am here with Ruben to talk all about communication today. So thanks so much for joining us today, Ruben. Would you like to start by introducing yourself and telling our listeners all about yourself?
Okay, thank you very much, Heidi. My name is Ruben Joki. I'm a consultant in obstetrics and maternal and fetal medicine at Sheffield Teaching Hospitals. I'm also the quality and safety lead for maternity safety in our trust.
Amazing. And I'm really excited about talking about communication today. If we start with families and how they tend to remember exactly how they were spoken to during their care, what are some of the small communication behaviours that can make the biggest difference to a parent's experience and help them feel safe during their care?
I think sometimes it's about being able to gauge who you're talking to. So everyone is different. Every couple, family that walk through your door is different. And you've got to try in a short space of time to work out what mode of communication is going to be best in terms of the people in front of you. So obviously when you're having very deep conversations, perhaps about things that are either unpalatable or difficult to kind of discuss, then you have to sort of do it in lots of small chunks. It's rarely built through one big conversation. It's lots of small movements where women and families need to feel seen and heard and ultimately respected. And for us, good communication is where the parent or the family or the woman feels that the professional in front of them is not just only clinically good at what they're doing, but genuinely present and interested in their concerns. So, I mean, it is not trite to say that it is about honesty, consistency, and as well as being kind and clear. There is a tendency for some people sometimes when they feel uncomfortable to talk around something that, again, they don't want to upset. They don't want to upset the person in front of them. But at the same time, we are duty bound to be able to say very clearly if there has been a problem or if there is something that is very wrong, that we need to be able to, for them to understand exactly what's going on rather than for them to feel confused or perhaps not be fully aware of what the problem is. So it's explaining what you're thinking, what you're worried about, and what the plan is without making them feel frightened or excluded. And I often say that. I'll say, I will just tell you exactly what's in my head so you understand why I'm saying the things that I'm saying. And it also comes really, the trust in us comes from us being able to say, we don't know. Sometimes we just don't know. Or we're going to say, I don't know this, but I know some people who might do, and I'll go and find out for you. They don't, most patients do not expect their doctor to know everything in front of them. And, even if you say, okay, well, I'm not sure what things are like today, we need to review this again. And they do respect that. So they don't expect perfection, but they expect openness and compassion and to feel that they matter.
Absolutely, that's really helpful. And in terms of listening as well, so that's conveying communication and providing transparent communication with explaining lots of details. How can professionals sort of really listen to parents? Because we hear this quite often, don't we, where parents don't feel particularly listened to. How can they make sure that listening is sort of frequently and consistently practiced, especially when they're in a really busy environment?
That's a really excellent point because again, to a certain extent, it depends on the context in which you're sort of talking to patients. So there are times in a clinical setting, if you're like I do a lot of pregnancy scanning, particularly with high risk pregnancies. So having to deliver um, bad news about an abnormality or a suspected abnormality, and those sort of conversations need to be held in small bits and pieces. Can be over a period of time, getting more and more information. But then you have the total opposite end of the scale. Like when I was on call yesterday for the obstetric unit, and you have to make decisions in a very short space of time. And there is a tendency for all of us when we are in an emergency situation to get things done in as quick a way as possible. But then it's never intentional, but we then forget about the woman in the middle. So for example, a woman came in yesterday. She was coming in for an induction of labor because her waters had gone and she'd had a previous perfectly normal, healthy baby before. Everything was fine. But when she came in, there were concerns about the baby's heart rate. And we had to mobilize people as quickly as possible, but at the same time, still had to then go directly to her, make sure the noise in the room was at an appropriate level for me to say, this is what I'm worried about. This is what I'm seeing. Okay. And on that basis, I think that we need to do this. And she was upset, but she understood. I gave her the opportunity to ask questions. I gave the partner and her mother, who was there, the opportunity to ask questions. And they were always kind of consulted at each stage. Are you okay with this? Do you understand what's going on? And sometimes that's really difficult to do in the heat of the moment because you're doing what you think you need to do for the safety of the baby or the mother, but actually then missing the person that you're actually treating out of it. It's not an easy skill, and we always get it. We all get it wrong sometimes. So this is not something that is it's easy to practice consistently all the time, but that's what we aim to try and do.
Yeah, I can imagine. I can picture that happening. It's hard to juggle everything and remember all of those points at the same time. And in terms of families, if families have sort of certain concerns, why is it so important for the professionals to take those concerns seriously? Even when something may not appear really urgent straight away.
Because parents and families remember everything. To you, when you're in that situation of dealing with emergencies, they are one of a number of emergencies. But for them, that is their only emergency, and that is what they will remember the littlest things. They'll remember the little words and stuff. They will remember the fact that the midwife, the doctor, the nurse, the healthcare worker all looked a bit stressed, or they looked distracted, or they were checking their time. Throwaway comments, things that that would have not been intentionally meant to hurt or disrespect them, but they'll remember all of this. So it's trying to be present in the moment to make sure that whatever they are focused on, if that's what's important to them, even if it doesn't seem important to you, you've got to try and address it to the best of your ability. So it is about it's about listening, obviously, with your ears, but then also looking and reading the faces and the kind of the emotion and what is it specifically, and then you dig and you find that it's something else, like they've come in with a symptom like a headache or whatever else, but actually this then leads them to remember some other relative that they thought they had a headache and then had something bad happen to them. So you don't know all of that. You have to be able to go and explore that in a way that that is sensitive to them, but obviously trying to work out what is it that they're worried about. Everyone, they've come in with a particular problem that seems completely unrelated or completely sort of, untroubling that for anyone else, and you have to then work out what is it about this, what are they worried about, and that's also a skill as well, and that takes time. And sometimes in emergency settings, particularly as I say on a labor ward, that becomes really difficult. But again, it's about trying to kind of maintain that consistency and get to the heart of the matter with keeping them at the forefront of things.
Mm, absolutely. And we find as a charity as well, if a parent has actually taken the time to ring up or to go in,
Yeah.
they generally have concerns because quite often they don't want to be a burden, or they might worry that their concerns are going to be dismissed. So how come maternity teams, communicate with parents and create an environment that makes them feel safe to do so, that encourages them to report any concerns that they might have?
So some of the things that we have, a lot of units will have and stuff is access to online services, things like QR codes for reduced movements and things. So the Thomas Charity, for example, they have the information about uh, fetal movements and things in lots of different languages. So that's another thing that I'd imagine we'll touch on at some point is communication with people for whom English is not their first language, or for people who are not British by birth and therefore can be culturally unaware of how some people operate, or that they are different to others as well. So there's written information, and technology helps with that, so that they have access to things in their own language, something that they're comfortable with. But then also that aside, you have to make it okay for them to be worried, and you'll have to say, you give them permission almost to speak up. It's not obviously permission, but you foster an environment in which it is okay to say, I'm worried about X, without feeling like they're going to be belittled, or feeling like they're going to be, as you described, being a burden. And many families worry about kind of wasting people's time, being embarrassed, or being labeled as anxious. And the language that we use is important, saying, please come back if you're worried, or we'd always rather check you. It's never a problem. And it just helps normalize help seeking. So, if they feel that when they come in, if they've needed to come in, that they felt welcomed and that they weren't being a problem, and they were, the staff were approachable, not judgmental, that kind of creates a culture of psychological safety, so that they feel that they'll be listened to respectfully, even if it is a minor concern.
Definitely, because you never know what's gonna happen next time, so you really wanna encourage them to come in. Um, I'm really pleased that you mentioned the information leaflet on reduced fetal movements. We actually helped co-produce that leaflet, and it has just been updated. There was a study done, lots of research, and so we've worked with Tommy's and other charities as well, and that leaflet has now been updated. So all the information on our website is all up to date. And talking about tools and translation tools, I know that Sheffield have been using our wellbeing wallets for quite some time now.
That's right.
So I was going to ask you, from your perspective, what impact that has had on empowering parents and encouraging them to seek help when they need it.
I mean, we've got a very, very dedicated obstetric and midwifery team to try and improving, kind of adverse outcomes. And we put in a lot of effort to make sure. I mean, again, going back to the sort of the population that perhaps is more culturally diverse, where language is a problem, where encounters with medical or midwifery professionals is seen as in a different way than perhaps people who've grown up in Britain feel it. So it's just about, as I say, encouraging families and women to know that we are there, we're present, we can be relied upon to take them seriously if they have worries or concerns, and then but also looking at wider problems like access to maternity care. We have full access available, and what we think is, what is accessible. There may be reasons why some families are not able to do that. So again, we have an example of a woman who has uh, not been able, or has not come to the hospital on 2 or 3 occasions in a row, despite us calling her every day, asking her to come in because we have concerns. But it's because her husband is out at work and she has no one to look after her other kids. At the end of the day, we can try and provide things where we can do, but sometimes life gets in the way for some people, and it's about being able to be culturally enough aware that, we can try and put things in place for them if there is an actual urgent medical obstetric midwifery need. But at the same time, these things will always happen, and we have to be able to try again, going back to the communication, to explain to them why we're worried. We're not asking them to come in to inconvenience them. It's about something that we have concerns that, if this doesn't happen, then something else might do. And that's the constant struggle, I think, really. That we've our unit is now sort of open access for things like the maternity assessment center for women to be able to come in. So even if that is a problem in terms of calling up and speaking to somebody, because again, we try and get interpreters on phones and things for women that don't speak English. So if they come in and they want to speak to somebody, we will then call a sort of an online language service to try and help communicate with them as well. So there's the actual physical aspect of communication when English isn't their first language. And then there's the other aspect of it of, being able to dig into what is it that they're worried about. And then sort of the other things that we've discussed about trying to kind of make them feel listened to. So yeah.
Absolutely. It sounds like you're doing great work at Sheffield.
I think we're trying. Well, I say everybody is trying to. But we know that there's always more that can be done. But I mean, the biggest investment for any health service, and particularly in an obstetric service, with all the things that are going on in maternity, the biggest investment isn't equipment or fancy machines. It is people. You've got to invest in your people, because if you invest in your people, things will be fine. There are plenty of things that we can do, a lot of low tech stuff that we do that is, that is perfectly in place, but the actual numbers of bodies there to be able to kind of accommodate, not just the numbers, but accommodate the complexity of some of the families coming through. That's what we really need.
Yeah, absolutely. And in terms of the language barriers and the different translation services you have, so obviously you issue the wellbeing wallets. There's lots of QR codes on there. There's a page specifically for Black and Asian parents. The QR codes come onto our website, which is translatable in 100 languages. I know midwives will print off certain pages, whether it's to do with breastfeeding or VBAC or whatever the topic is. They'll print that off in the language for that parent. But what other tools do you use at Sheffield to sort of overcome language barriers?
Well, like I say, we ensure that every single person who may not be of English kind of origin or British origin in terms of English as their first language, we will always ask them, would they like an interpreter? Do they want an interpreter? And a lot of times they will choose family members. Now, again, we are advised to not encourage this, but if the woman herself refuses or declines to have an interpreter, a non-family member, sort of, then we have to respect that and say, okay. Or if we think that there's something particularly important that we don't think that the family member is, or that they're going to struggle with, then we'll say, we're really sorry. We're very happy for the family member to sit in and kind of add bits to, but I think this needs someone, hopefully with a more professional sort of translating ability to be able to explain things. That becomes very challenging in the emergency situation, because again, there are languages that are very difficult to get hold of on an online service, particularly on weekends and things, because there just aren't that many people around who are either bilingual or speak that particular language necessarily available at all times, day and night. So that's where the challenge really comes in. But in the more sort of general clinic setting and things, then again, the midwives are all trained to ask that almost as a, excuse me, as a standard question. Are you comfortable in English? Would you like us to get an interpreter for you? So it's never seen as a problem. We don't make, we certainly don't make an issue of it. We just go, that's fine. We'll get, and they access the service, and they sort of then have that communication with them. So it does depend on the setting, but every single woman is asked about an interpreter where appropriate.
That's fabulous. That's really good. And I'm just thinking about how our wellbeing wallet sort of improved the communication between midwives and parents, and talking about, certain signs and symptoms that they need to be aware of. What impact have you seen in Sheffield?
I think there's a lot more, excuse me, there's a lot more readiness now for the women to report things like reduced movements. So we don't have generally now, thankfully, women who say, oh, I've not felt a baby move since before the weekend. But then your heart sinks and you just think, if they access things earlier. And then just same thing, a lot of actual investment has gone into redeveloping our maternity assessment center. There used to be just a triage area, but now there's a full maternity assessment center, someone on the phones, people recording, the conversations and things like that. So there's that side of it in terms of if they have an acute emergency. And then obviously, as I say, working on labor ward in an acute setting, making sure that, as I say, if there is something going on, we try and explain to them in as clear a way as possible what it is that we're worried about. And we will still sometimes get pushback that we will recommend a particular line of, sort of, we need to go to theatre, we need to do whatever. And then they will say, I don't want to do that. And then it's again about trying to explain things without then sounding like you're forcing something. Because at the end of the day, if they have capacity, they are allowed to make that decision. But it's being really, really clear that this is why we are recommending this particular line of action. And, there aren't very many specialties where, unfortunately, we have such a small time window sometimes to make a massive difference. And that becomes really challenging again so again, that communication without it then becoming an enforcement of your views or your kind of your experience on them. And that's a really difficult balance to get right.
Mm. Well, that's fantastic to hear that, the wallets are really helping to sort of change that taboo and change that culture in, parents reporting reduced movements a lot quicker than they used to. That's fantastic. But how do you get that balance right then between, being in quite a urgent situation, having to make quite a quick decision, but also giving the parent that informed choice in a non-biased way so that they can make their own informed choices? How do you do that?
So, I mean, some of it is very basic level stuff, things that we all know we should do, but sometimes gets forgotten. So, um, it is literally about sometimes getting down to their level. What I mean is they're often on a bed or they're lying down or they're in pain or whatever else. It is about making them feel the focus of the intention at that time. And that's really difficult, again, when you've got a short clinical window, but everyone's got that 1 to 2 minutes where they can go around to the side where the woman is facing, kneel down, sit down, whatever else, ask for as much quiet to be, kind of for quiet to be in the room as much as possible, and to just say, I am concerned that this is going on. Like I say, that it becomes more challenging than when you have to use somebody, an electronic voice at the end of a phone or a phone interpreting service, but you will say, this is what we're worried about, and this is what I want to do. And again, if you speak with genuine compassion and with sort of a heart, informing them of what it is that you are worried about, then I think most of the time people are willing to accept what you're saying, and the course of action that you're proposing, really. So you want to avoid you don't want to frighten people. You want to inform and, if at all possible, empower them. And most parents cope with honest information when it's delivered, in a calm way, clearly, and with context. So, this is what normal is. This is now not what we would expect. This is why we want to do this, the next step. So you try and avoid either extreme, not, false reassurance or overwhelming fear. And you would say, you want to, this is going on at the time, but these are things that we are concerned about in the here and now, and we think that doing something in this, at this minute will prevent harm or reduce harm to you and your baby. And that approach maintains reassurance while still prioritizing this kind of the safety element.
Absolutely. It's quite hard to get that balance right, isn't it? Because you don't want to cause anxiety and fear and panic. And yet at the same time, you want to communicate the risks honestly and maintain reassurance and trust. So that must be quite a skill in itself.
It is, and the thing is, as I say, we are never we aim for perfection, but we will still get it wrong. I think all of us will, all of us who have a degree of insight, and everybody who works in maternity services cares. They work in that field because they do care, and they try really hard, but sometimes we don't get it right. We allow, we're humans at the end of the day. Human factors always creep into it. And there's a much greater recognition of human factors in terms of now why things happen, not just in maternity services, but in all healthcare. You know, um, People being tired, people being hungry, people being worried about something else going on. This sheer volume of work, the acuity, will be what we refer to in the unit as the acuity. Things go on, and that's why things sometimes get missed. And the things that will get missed are the handover element of it. Okay, so the kind of someone has come in with 3 problems and you're handing over, but you mentioned 2 of them without mentioning the third one, which then leads on to an assumption, a false assumption about why someone else is there, why that person is there, which then means that something else that should have been done gets missed. So you see, it's this knock-on, this rolling effect, and nobody intended to do that. They were, to the best of their ability, they were trying to hand over a clinical problem, but because they're all human, things sometimes get missed. So, you try and improve things by ensuring your written handover is good enough. You try and do it in as structured a way as possible. But, that things will still happen that, again, you don't intend. Or the communication issue that you've come in, it's your 3rd emergency in a row, and you're trying to sort out a very busy labor ward, and you end up sort of calling out or sort of barking instructions, perhaps, that, again, the woman doesn't understand what's going on, and you then have to try and explain in a very rushed way what it is you're doing. And that's when, you look back on it. Sometimes you'll go back and look and go, I could have done a bit better there. And, we never sort of accept anything less than the best if we can do, but we know we get it wrong sometimes. And I think that is important to say, that nobody intends ever to kind of go into that situation wanting to upset somebody, but we know that we will sometimes, and that's hard. That's hard. And it is about experience as well. So, you imagine that some of the junior doctors and some of the junior midwives and stuff, they're only in their kind of early to mid-20s. It's quite a stressful situation for them if they've never encountered it before.
Definitely. So in your experience, 'cause you've got lots of experience and wisdom,
I'm just old, Heidi. That's all. It's just old.
what are your learnings? What are your learnings? What would you say could be effective communication? What does that look like, especially for, like you've just mentioned, the handovers, shift changes, being under pressure? What would effective communication be like to make sure that, all the details have been relayed?
So I think we've covered a lot of it. So in terms of effective communication, because you've got to communicate with the families in front of you, and you've got to communicate effectively with the people who you work with. So, never belittle, never kind of, as I say, underestimate what is worrying the families or whatever else. You just, again, try and listen to their concerns, try and see what it is that they are most worried about, and deal with those things first. If you are, as I say, in a non-urgent clinical setting, it's ensuring that you have, you've documented things in whatever way, whether it's written down in the handheld records on an electronic system, a letter or an email to somebody to ask them to review this woman or perform, different counseling. In the urgent clinical setting, It's about being able to escalate concerns appropriately. So for the juniors, if giving them that environment to say, I'm worried about this heart rate, or I'm worried about this woman's symptoms, or this woman's pain, or whatever else, and being able to allow them to do that without fear of the saying, there's nothing, why are you bothering me with this? Um, so there's a whole range of things. It is never, as with most things in life, it's never just one thing, is it? It's a series of things. So for the woman, it's being able to, as I say, get onto their level, making sure that they are the only person that matters in that there and then. And then, as I say, with your colleagues, giving them a clear kind of sort of précis of what it is that you need from them. So if you're worried about something, go, we are anticipating a major hemorrhage. We are anticipating there to be surgical problems. We are anticipating the baby to be in a poor condition. We need to have our team ready and standby. So it's about being able to kind of address all of these things clearly, so that it doesn't then become a surprise, or or a mismanaged opportunity.
Absolutely. So escalation is
Yes.
a key word at the moment. I call it a buzzword because that has been coming up a lot in the reports that we've seen and recommendations in these reports. And it's obviously really important for effective escalation. So, how can we improve escalation between midwives and obstetricians? I think you mentioned the barrier just a minute ago about perhaps not feeling comfortable approaching certain staff members. How can we try and change that culture and improve on that escalation, because it is just so vital?
I think a lot of that has already started to happen. So we have, obviously we have labor wards with a team leader or a coordinator and things, and the midwife, for example, it will always be um, advised to go and seek their advice first, and then if they felt potentially uncomfortable, perhaps because of their junior status or because they just weren't sure, or they had some anxiety, then the team leader can always come to us and say, midwife X is worried about this. Could you come and have a look? I've had a look, and I think I agree with their, sort of evaluation of it. And then obviously in terms of the obstetricians, you'd have various grades, from registrar to consultant, depending on, time of day and whatever else, to be able to. So there are plenty of opportunities for someone to be able to escalate concerns through different pathways. And as I say, I think generally speaking, not just in Sheffield, elsewhere, we are getting much better at that. Um, we've obviously heard in previous reports about this sort of the kind of things that we don't want to hear, the toxic environment between midwifery and obstetric staff, and the fact of us and them culture. And I can only speak for where I've been working for the last 20 years, is that I don't see that. You will always have disagreements. You will always have potentially different ways of how you think things could be managed. But I would say that, on the whole, we have a very good working relationship with our colleagues. And, we have, obviously, again, in obstetrics, such a diverse range of people that we need to work with in a very short space of time. So as obstetricians, we need our midwifery, our anesthetic, and our neonatal colleagues, as well as our support workers, our infant feeding team,
Mm.
our maternity support work. We need all of them. We need everybody, and everyone plays a role. Everyone plays a role, and they are all just as important as everyone else.
100%. I couldn't agree more. You all need each other to make it work. What other barriers do you see between multidisciplinary teams, and how can, that be overcome?
Some of it is just some of it is just, unfortunately, resource management. So, particularly with some of the things that I do, or my other colleagues in fetal medicine, where we want to deliver premature babies that may need time on the special care unit, or surgical problems, so that we need to deliver them so that they can get transferred to for where we were, Sheffield Children's Hospital, or need to be admitted in a planned way. um, and if the neonatal unit is at capacity, because at the end of the day, they are funded regionally. So, for example, where we work as well, we are the only level 3 center in our region. So, therefore, they are obliged to have transfers of babies from other units that may not have ever been, anywhere near our maternity services, but that is an obligation that they are there to look after these babies, because that's where the specialist that's where the specialist unit is, in terms of being able to manage breathing and other very, problems of very premature babies. So sometimes we have our frustrations of wanting to deliver people because we are worried about either maternal well-being or baby's well-being. And we then have to have the discussion and say, well, we don't have capacity for this. We're going to have to think, if you are that worried, you're going to have to think about potentially transferring the woman elsewhere to another level 3 unit that has capacity. So it's not a problem unique to us, because we get transfers in from other places as well where there is no capacity and then we end up in the same situation. And then back to the whole thing about communication. So what you're doing potentially, if you're the opposite, if you're receiving someone from elsewhere, it's about being able to make sure that you've got as much information as you can do, going and talking to the woman and a partner they're going to be frightened, because they will have been wherever they've been near their family for the whole pregnancy, and then told that they've got to come to Sheffield. And then we have to be able to make them feel welcome, make them know that obviously we are going to look after them in exactly the same way as someone who started their journey in Sheffield would have done. And it'll be the same for, you would hope that if our ladies had to go elsewhere, that they were afforded the same level of respect and communication, in that we would want to try and kind of, sort of give those people who've come into us. So a lot of the time it is about resource management, which is difficult because there is very little you can do. If you are at capacity, if your neonatal nursing staffing is at capacity and they can't exceed that because they have their limit, or we do not have, the theatre availability to do something, again, that we think we need to. It's about managing that and potentially prioritizing things above others as well. So that's the hardest bit of it, actually. We know the clinical decisions that need to be made, but sometimes we're not able to actively, kind of follow through with those.
So do you hope some of those changes will come out of the national inquiry recommendations that's due to report next month? What would you like to see in there?
I mean, I think what everyone would like to see is that there's basically unlimited funding for all of the things that we want to do, but we know that's not reality, unfortunately. We will be, we are like anyone else. We are. It is incumbent on us to manage our own budget and consider what we prioritize in favor of other things. But everything in maternity is so important, and as you say, that the scale of the number of reviews that have come out about how women haven't felt listened to for years, or haven't been feeling like they've been able to access care in the way they want to. It's just it's just opened up the whole conversation about how women have felt, sort of underfunded, women's services generally, not just in maternity, but also in gynecology, how grossly underfunded, half our population, entire half of the entire population is not treated in a way that they feel that they need to be. And that's very sad to hear. It's very sad to hear. So, I mean, as I say, with the things that we would want to hear about would be more funding, but obviously everyone thinks that they need more funding. But, for the things that women are telling us that they would prefer to have, or they would want to see, that would be a massive investment. And, we have had a massive investment in buildings in terms of, renovation work and things like that to update our actual kind of infrastructure. But now what we need is the people to be able to make all of these things work.
Absolutely. So having the people to do that, I'm just thinking about newly qualified midwives. We want to develop confident, compassionate midwives. What would you say to them to help with their communication skills when they're just starting out?
So basically, but I mean, one thing you could do immediately would be to replace reflex reassurance with curiosity. So what do I mean by that? So rather than sort of saying, or someone will say to you, a woman will say, I'm worried about this. Oh, I'm sure it'll be fine, or whatever else. The kind of that blanket thing that, again, it's not meant to be dismissive. They're trying to be kind and compassionate, but actually then go, oh, why are you worried about that? Is there anything particular that's actually making you anxious about that? And then they'll tell you, as I say, about the friend or their sister or someone else that had a bad outcome with something similar. And say, what is it that's worrying you? So giving them that chance to then basically open that conversation up from something very small, changes the dynamic of a conversation. It makes them feel heard, as I say, improves clinical understanding, and just generally creates safer care. And that's what I mean about, a lot of what we do is very low tech. It is about listening and saying, you know would it help for you to come back and talk about this again? And just giving them that opportunity. As I say, we're down in the fetal medicine unit, for example, you may have satisfied yourself that a baby is growing normally, is moving normally, and everything is okay, but they're still worried. Now, by every metric and every guideline, you might be saying they don't need to come back. They don't need to have an extra appointment. They don't need to, you know, utilize more resources, things that you're already struggling with. But if for that woman, that extra one appointment in a week's time or an extra couple of weeks is going to make all the difference to them, then, sometimes we have to be able to be flexible and deal with the people in front of them rather than just in pure clinical, black and white guidelines, unfortunately. And that's very difficult to do because it's such an emotive field of healthcare that actually a lot of the guidelines and things don't really account for, the fact that, families are going through something that they may only do once in their life. If you're lucky enough, you can do it more than once successfully, but, you see it 100 times a day. That's the only time they're going to necessarily be in and having a baby. So it's trying to remember all of that while still maintaining everything else. Yeah. You feel like a juggler with 100 plates on one, spinning at one time. Yeah.
Every encounter counts, we always say. So just to finish off,
Sure.
if every maternity professional could make just one communication change tomorrow that would really help to improve safety and trust for families, what would you want that to be?
Basically giving them the time to listen, giving them time to talk and to listen. So just being able to hear everything that they're worried about, explore with it further. If they may come out with something like, I've got a really bad, as I say, I've got really bad stomach ache. And then, you go, okay. And once you've satisfied yourself that there's nothing clinically else, then it's, as I say, it's going into the curiosity of why, is there something that's worrying you? Are you anxious about something else? Has something happened at home that's made you that, and again, there are ways of being able to do this in just, in a very generic way. So you kind of talk around things and give them the opportunity to say more. So, staying silent, listening to what they say, all the kind of the things that you're trained to do generally anyway, and what all good listeners do, which is to nod at the right time, make eye contact, making them feel listened to, not writing, not playing on the, well, then no one will be playing on the phone, but you know what I mean, not necessarily, typing on a computer, doing something where they feel like they're a burden or a nuisance. And it is a really simple thing. It is as simple as that. It's not big, it's not big training days. It's not big kind of, as I say, massive changes in technology. It's just staying silent and giving them the chance to talk.
I love that. That is so helpful. Well, thank you so much for joining us today,
It's a
Ruben.
pleasure. Thank you so much for having me.
We've covered so much. And I wish you all the best with your fabulous work in Sheffield.
Thank you very much, Heidi, and good luck for you. Your charity is amazing, and hopefully it keeps going from strength to strength.
Thank you so much.
Take care.
Fletcher Solicitors are proud to support the Mama Academy by sponsoring this podcast series. At Fletcher Solicitors, we champion better maternity care. For every birth, for every baby, for every family.
If you enjoyed listening to this episode, share it with a friend or colleague. Make sure you follow us so you don't miss out on our next episode. If you'd like to support our work by fundraising or volunteering, please email contact@mamaacademy.org.uk. For more information on pregnancy and maternity services, please visit our website at www.mamaacademy.org.uk. We're also on all of your favourite social media channels. See you next time!